Hi guys, today let's learn about shoulder dystocia, an obstetric emergency which is very important for all the obstetrician gynecologists to know. This is very important not just from your day-to-day practice but also a very important potential viva question in your practical MS exams. This is also a very repeated topic of previous year in the NEET PG exam. Even this year they had asked about shoulder dystocia. So let's learn about it. Hi, I'm Dr. Sarani Chatterjee, Senior Resident Obs in Gynae. So let's dive deep into the topic. So first of all, how do you define shoulder dystocia? Shoulder dystocia is defined when the body does not deliver, or the shoulders don't deliver even after the delivery of it for more than 60 seconds or 1 minute. Okay, so the cutoff is 1 minute. This is very important. You will also see that the head starts receding back. Okay, once the head has come out, it starts receding back, and this is known as the turtle sign. So this is very important. What is the pathophysiology of shoulder dystocia? It is mainly that the anterior shoulder gets impacted under the maternal symphysis pubis. It may also happen that the posterior shoulder has got impacted in the sacral promontory. But remember that the anterior cause is more common than the posterior cause. Some of the risk factors which can potentiate or which can lead to shoulder dystocia. Very important is that fetal macrosomia. So disproportionately large body in relation to the head, more than 4.5 kg. Excessive weight gain during pregnancy. So the maternal weight gain can also lead to shoulder dystocia of the baby. Obesity, diabetes, multiparity, post-term pregnancies, short stature, any anomaly in the fetus, and the anomaly of the pelvis. Also remember that precipitate second stage of labor, protracted active phase of the first stage of labor, operative vaginal delivery, prolonged second stage, short umbilical cord. Now these are the risk factors which can lead to shoulder dystocia, and when you are dealing with such cases you have to be very alert. Remember that once you diagnose shoulder dystocia, you have to tell the mother to stop pushing, because bearing down can even further aggravate the shoulder dystocia. Now I'm pretty sure you all must be knowing the helper mnemonic for shoulder dystocia management. So let's try to elaborate on that. So once you find that there is shoulder dystocia, immediately call for help. You have to call your seniors. Your senior obstetrician presence is very, very important. Anesthesiologist, pediatrician is also very important to be there. Drain the bladder, that is empty the bladder. Episiotomy should be given in a very liberal fashion to increase the space for any manipulation. Gentle traction should be given, and definitely you need a very skilled assistant also to perform the rest of the maneuvers. So the first maneuver that we do is the McRoberts maneuver. That is, you hyperflex the thighs and you abduct it. Okay, so hyperflexion and abduction. So let me show you the image over here. So you can see that there is hyperflexion and abduction of the thighs. So this is what is called as the McRoberts maneuver. So you can see that one assistant is performing the McRoberts maneuver, where she is hyperflexing the thigh and abducting it at the same time. Now why is this done? Now this increases the relative anterior posterior diameter of the pelvis and straightens the lumbosacral angle and rotates the maternal pelvis towards the mother's head. Okay, so towards the mother's head. So you can imagine that the AP diameter of the pelvis will increase. So when you are doing this, so basically it causes cephalic rotation of the pubic symphysis and flattening of the sacrum, thus increasing the diameter. So this McRoberts maneuver, remember, has a success rate of almost 90% and very low complication rate. Remember that you need two assistants on both the sides to perform this maneuver on both the sides. Okay, along with this you can see that her one more hand is doing a suprapubic pressure. Mind it is not fundal pressure, it is suprapubic pressure. Now this is very important in case of shoulder dystocia. So the assistant should apply firmly a suprapubic pressure with palm or fist. Okay, so this causes the adduction of the shoulders of the baby and tries to bring them in the widest possible oblique diameter. So you are not just reducing the diameters of the shoulder of the fetus, also by pressing you are causing the fetus to rotate in the oblique diameter of the pelvis so that it comes out. Okay, so this is a very important thing. So metropods along with suprapubic pressure should ideally be given. Then you have to extract the posterior arm. So you're using the person who is conducting delivery has to insert the finger and has to gently take out the posterior arm of the baby in a sweeping fashion. Okay, so if for that you need to see which side is the fetal abdomen. So if the fetal abdomen faces the maternal right, then you have to use the left hand, whereas if it's the other way around, you have to use your right hand. Now the next, the anterior shoulder has to be removed. Also for this you have another maneuver called internal rotation or the rotational maneuver. Now this is also called as the wood corkscrew maneuver. Okay, so in this you rotate the posterior shoulder 180 degree in a corkscrew fashion to the anterior, and then anterior shoulder comes to the posterior position, and that's how you release the both the arms. Okay, so basically again the principle is same, where you are bringing the bisacromial diameter into the oblique diameter of the pelvis. Last is the Rubens maneuver. In Rubens maneuver, you are applying pressure on the maternal abdomen. Fetal shoulders are first rocked from side to side. If it fails, the pelvic hand reaches easily accessible fetal shoulder, which is moved across the chest's anterior surface, pushes the fetus slightly upward to facilitate rotation. If the anterior shoulder is tightly under the symphysis pubis. So it's a rotational maneuver basically. Okay, so Wood's corkscrew maneuver was where you were turning it completely 180 degree, whereas in Rubens maneuver you are partially rotating it to just disimpact the shoulder which might have been impacted under the pubic symphysis, which is the pathophysiology in shoulder dystocia. So if all these maneuvers fail, then you are going to go for a Gaskin all-four maneuver. In this you are going to ask the mother, as you can see in this image, this is the Gaskin all-four. She is on her forelimbs. Okay, you're going to put her in this position and try to deliver the baby. Now this also has a good success rate. Okay, basically all these maneuvers are trying to increase the space for the baby to get delivered. 80% of the time it may get delivered by the time you do the Gaskin all-four. Okay, so this is very important. Now lastly, if everything fails, okay, so you have tried all the maneuvers, then you did Gaskin all-four also, it didn't work out, then you have to resort to the last one, that is the Zavanelli. Zavanelli is when you have to push the fetal head inside and take her up for a cesarean section. So it's also known as the cephalic restitution abdominal rescue. So in this you are going to give up and you are going to take her for an immediate cesarean section, and that is why I said the presence of anesthesiologist and pediatrician is also very important when you are dealing with a case of shoulder dystocia. So in a nutshell, if I have to summarize, the management of shoulder dystocia call for help, drain the bladder, give episiotomy. Remember that you need two assistants on each side. So for performing the maneuvers, the first maneuver is your McRoberts maneuver. Okay, most of the cases will be managed if you do the McRoberts maneuver correctly along with the suprapubic pressure. Then you have to extract the posterior arm. You can do the next Wood corkscrew maneuver and the Rubens maneuver. Then If nothing works, you have to put her on Gaskin all 4, and still if she doesn't deliver, you're going to go for a Zavanelli method. Remember that once you have diagnosed shoulder dystocia, you don't have much time, and all these things should be performed very quickly, rapidly, in a skilled way, and you have only 5 minutes to do it. And remember that you can perform these maneuver maximum 2 to 3 times before moving to the next maneuver. But remember, you have a ticking time bomb there where you have only 5 minutes to take up a decision of doing a cesarean section. Always keep your senior informed, and in case this doesn't work, you have to go for an emergency cesarean section. I hope you have understood this very important, highly important emergency obstetric topic. It's very important. The images have been repeatedly asked in various exams, and the questions have been asked in various formats about shoulder dystocia. So it's very important for all of you to remember. If you have any doubt, feel free to write in the comment section. I'll be glad to help. That's all for today. Have a great day ahead.